Welcome and thank you for joining. My name is Trixie Thibodeau, Health Educator for Community Health at Atlantic Health Systems. Today's webinar, Women's Heart Health, and being presented by Dr. Nupur Shah. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try to get through all the questions at the end of the presentation.
All right, so let's get started. Today, we're going to learn about women's heart health. I'm Dr. Nupur Shah. I work with AMG Cardiology at Hackettstown and Sparta in Newton. So a little bit about me. My training in medicine has been done in New York and Michigan, and my cardiology training was in Alabama. My specific area of interest is definitely heart disease in pregnancy, women's heart health, cardiac imaging, and heart failure management, and of course, preventive cardiology, because I believe that one, we have to prevent all the risk factors so that the cardiac disease does not happen. These are the locations I work at. So on the top left, you see Hackettstown Medical Center, my office in Hackettstown, and then Newton Medical Center, and my office in Sparta. So the goals of this talk is one, to know the statistics of heart disease in women, the risk factors which are specific to women's cardiovascular health, including pregnancy and heart disease, to know your heart health numbers and how to keep them in check, and the challenges to address, particularly when it comes to women's heart health, how to recognize symptoms when you're having a heart attack, and what to do when you're having a heart attack. So since this is about women's heart health, I want to emphasize how much the burden of cardiovascular disease in women exists in current era. Total 35% of all deaths in the women worldwide are caused by cardiovascular disease. This is a study published in Lancet in 2019, where they saw that there were 275 million women who were diagnosed of heart disease, of which around 9 million women died from cardiovascular disease. And yet, despite such a burden of the heart disease in women, the cardiovascular disease among women is still understudied, under-recognized, under-diagnosed, under-treated, and women are underrepresented in clinical trials. So my goal is to spread the awareness, make women aware of what specific symptoms are there, so that we can start drifting this graph into the other direction. So this is again telling how much the burden of cardiovascular disease and death is in United States. From American Heart Association in 2017, it shows almost more than 400,000 female on the top left, as you can see, dies from cardiovascular disease. And that is more than all the cancers combined. You can see this around 400,000 cancers, followed by accidents, diabetes, and all other causes of the death. So what are the challenges that we have to address? First and foremost, the lack of awareness. The heart disease, as we know, is the leading cause of death in women, exceeding all cancers combined. But unfortunately, only 44% of women are aware of this fact. And as we saw from the latest study in 2017, that more than 400,000 women, which is 1 in 3 women, die from heart disease every year in the United States. 1 woman in every 90 seconds suffer from a heart attack. And so we have to spread the awareness. Second, women does not know how exactly they're present. They often present with chest pain, but they also present with other non-cardiac symptoms that are associated with the chest pain. So what ends up happening is they delay in seeking care, and then they attribute these symptoms more to other non-cardiac causes. And then that results in a delay in the diagnosis and treatment in a woman who is presenting with heart attack. So first of all, about emphasizing on the lack of awareness. So again, this is a study from 2017 published in American College of Cardiology journal. So only 45% of the women know that cardiovascular disease is the #1 killer. So we need to raise the awareness, as we know. 26% of the women actually find it embarrassing to talk about their weight or any heart symptoms that they are having. So we need to destigmatize the disease risk and counteract the stereotypes that we have. And it's not just the patients, it also comes to healthcare providers who can underestimate women presenting with heart attack. As the study says, only 40% of the routine care includes a heart risk check. Only around 40%, again, primary care physicians make cardiovascular disease a top priority. And only 22% of the primary care physicians and 42% of the cardiology feel well prepared to assess cardiovascular disease risk. So we need to invest in cardiovascular disease research, and women need to advocate from themselves when they are seeing physicians, when they're going to the ER, when they think that something is wrong, then they need to advocate that they need better care and evaluation. So just to explain, how does a heart attack occur? Over time, what happens is the cholesterol deposits in the wall of the coronary arteries, which is the arteries around the heart, and they form a plaque. Now, if this plaque is unstable, it can rupture or break open, and then that can trigger a blood clot, which can form around there. The blood clot then can partially or completely block the artery and then stop the blood supply to the heart muscle. And then this lack of blood flow and oxygen to the heart muscle causes a heart attack. And with that, the heart muscle cells begin to die, and that causes a myocardial infarction, which is dead tissue of the heart muscles. So this cartoon would depict what I'm talking about. So basically, I'm sorry. So this is where this is a normal coronary artery. And on the bottom, you see how the plaque is formed, which is just nothing but cholesterol and other substances. When the plaque is formed, it becomes inflammatory. So when you have any sorts of triggers like viral infection or any disease or any arrhythmia that's going on in your body, all the inflammatory cells increases, and that can create that hole in the plaque, or the plaque can rupture. When that happens and the blood is flowing through there, that creates the atherosclerosis with the blood clot over here. And on the top right, you can see how when the blood clots, it can either stop the blood flow in that artery, or either partially or completely. But then you see how the heart muscles start to die because of lack of blood supply and lack of oxygen. So because now we know what the heart attack is, what we should do, and what are the growing concerns in America that we need to address. So unfortunately, 36% of the Americans have obesity, 30% are sedentary and are physically inactive. Around 30% have high blood pressure, and the number keeps on growing every single day. 17% of the population are smoking cigarettes, 12% have high cholesterol, and 9% are diagnosed with diabetes. So these are the major risk factors in the burden in the US. On the top right, you can see there are certain things you cannot change, like age, family history, if you have previous history of heart disease, or sex, because initially male will have more risk of having heart disease than female. But after the female hits menopause, and we're going to address it later in the lecture, female become more risk to getting cardiovascular disease. But there are many things that you can risk factors in creating cardiovascular disease. So these are the 8 modifiable cardiovascular risk factors, also known as Life's Essential 8. These are the 8 things that we need to get better. So eat better, be more active, quit using tobacco, get healthy sleep, manage weight, control cholesterol, and manage blood sugar, and manage blood pressure. So we're going to break it down and explain what exactly we can do about that. So first of all, eat healthy. So definitely the emphasis is put on eating more fruits and vegetables, more whole grain foods. They use healthy source of proteins like fish, seafood, legumes, nuts, low fat or fat-free dairy, poultry, and lean meat. Use liquid plant oil like soybean oil or canola oil. Also olive oil and avocado oil is a good one. There's a misconception that coconut oil is very healthy, but no, it can increase your LDL cholesterol, the bad cholesterol, and can increase the risk of having heart disease in the future. What you shouldn't be doing is minimizing on the beverages and foods with added sugars, which unfortunately most of the packaged foods have sugars and salt in it. Avoid ultra processed food, avoid processed meat, avoid food that is high in salt, less consumption of alcohol, and of course, avoid tropic oils. So I always tell my patients, like when you go to the grocery store or market, stick to the aisle which has the produce section, which has all the fresh vegetables and fruits and all of that. And then they go to the frozen section, they can buy frozen vegetables and things from there. But in between all the aisles, if you look at it, they all have packaged and processed food, and everything is unhealthy. Last but not the least, always read the ingredients. The box would say that it's very healthy, it's protein rich and all of that. But when you look at the ingredients, it is filled with sugar and bad palm oil and other bad oil and lots of other processed food items that you should be avoid. Definitely avoid saturated fat and trans fat when you read it on the label. The second thing to do is being more active. So per American Heart Association, one should exercise at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity of activity every week. And if you're starting, that's fine. You can get there. You may not hit 150 minutes in your first week, but you just have to get there. And the simplest way to do it is just start walking. It's free, it's easy, and can be done anywhere. You can even walk, and there are now new apps, and after COVID, everything is virtual. So you can join an app, just get some YouTube videos, and then you can also walk at home in your own pace. The goal is to not be sedentary and do as much as you can. Add moderate to high intensity muscle strengthening activity like resistance or weights at least 2 days a week. Now, after women reach their menopausal age, sometimes my patients would ask that they have history of falls and they're muscle weak. They don't have that much strength. One thing they could have done is after the age of 30, start building your muscles, because at the age of after age 30, you start losing muscle. 30 is such a young age, but you start losing muscle every year. So definitely encourage in doing resistance activity, weight training, and then you can increase the amount and intensity gradually over time. But that would help you gain and keep that strength later in the years when you grow old, and increase this, improves the balance, improves the strength, and being able to just do other activities. Of course, helps with the cardiovascular health too. And of course, spend less time sitting. Life has now become 9 to 5 desk job, sedentary lifestyle. So make sure either use a standing desk, or if you're doing meetings, some people do it on the treadmill, that they set up their laptop in front of the treadmill and then they would walk and do their meetings if that's what they're doing. Try to move around. Keep an alarm in your watch or in your phone, which just tells you and reminds you that you need to just take a stroll around, walk, and stretch yourself in between those sedentary work hours, and definitely go for exercise at the end of the day. So these are the heart health numbers. As I mentioned, you should top 5 numbers to remember. 1, your blood sugar. Fasting should be less than 100. 2 hours after eating should be less than 140. Your blood pressure should be less than 120/80. Your cholesterol, the total cholesterol, should be less than 200. And your body weight, the BMI, which we calculate based on the gender, age, height, that should be between 18.6 to 24.9. If you keep your numbers in check, that prevents the risk factors, and that prevents the cardiovascular events from happening. So just know your numbers and get it under control. So talking about hypertension, so for women particularly, hypertension during pregnancy, especially if they had history of preeclampsia, that is a significant risk factor for developing hypertension later in the life. And the hormonal changes during menopause, that can also contribute to an increased risk of hypertension. Other risk factors for high blood pressure in women is obesity, smoking, sedentary lifestyle, family history, ethnicity, as Black people would have more a risk of having high blood pressure per the latest guidelines, and also certain reproductive health issues like PCOS, polycystic ovarian syndrome. This all can increase the risk of having high blood pressure in women when compared to men. Also, compared to men, women with high blood pressure have a higher risk of heart attack, heart failure, and death from the complications of the high blood pressure. So it's very important for women to keep their blood pressure under check. Now, if you do not have any cardiovascular risk factors, then the goal blood pressure should be less than the top number, which is the systolic blood pressure, should be less than 140. And the bottom number, which is the diastolic blood pressure, should be less than 90. If you have any cardiovascular risk factors, which we are talking right now, high blood pressure, diabetes, any heart disease history, then the top number goal should be less than 130 and the bottom number goal should be less than 80. Now, it always depends, and that's why you need to see a cardiologist, because certain particular patients have different blood pressure goal criteria. But in general, this is what it is. So you need to keep your blood pressure around 120/80 and definitely less than 130/80. Talking about high cholesterol. So don't just look at the total cholesterol. The two most important components on the top left, on the left side of the screen, as you're seeing, is the HDL cholesterol and the LDL cholesterol. So HDL cholesterol is what's called the good cholesterol. The higher the number, the better it is. What it does is it removes the cholesterol from the arteries to the liver and then disposes off from your system. And that helps reduce the risk of heart disease and stroke. Any level above 60 is considered protective for developing any heart disease. That's the case because it has more protein and less cholesterol in that HDL molecule. On the right side, you're seeing LDL cholesterol. That's something called bad cholesterol. That's the one that deposits in the arteries, and that's causing the plaque formation. The plaque is what's causing the blood clot, inviting the blood clot and causing a heart attack. So definitely lower the LDL, better it is. Less than 100 for anyone without any risk factors. But then if you are having heart disease, then your doctor would tell you either LDL should be targeted to less than 70. And now the European guidelines are saying it if you have certain high-risk diseases, if you're diabetic and if you had significant heart disease in the past or stents or bypass, then the goal should be less than 55. So lower the better for people who have heart disease or risk factors. But even if you don't have it, the LDL should be less than 100, the HDL should be more than 60. On the right side, you are seeing something called, now it's the newer research and everything has come up with two more additional important molecules when it comes to cholesterol. The first is lipoprotein A, also known as LP little a. That is a genetically inherited and independent risk factor for heart disease. So now doctors are measuring LP little a when you have strong family history of heart disease and your cholesterol is not controlled. That would help us know, one, if that's high, it's directly linked to having increased risk of heart events in the future. The second one is ApoB or apolipoprotein B. This is, again, causes increased risk of plaque formation, and then higher the number, then it has increased risk of developing heart disease in the future. So if you have high cholesterol, and especially if you have very strong family history of high cholesterol, ask your doctor to measure LP little a and ApoB. That would give us more risk stratification of having events in the future and how tightly we should control the LDL by either lifestyle, of course, always lifestyle, and pharmacological medications as necessary. The goal number, the ApoB, should be less than 130 and LP little a should be less than 50. So now also I want you to know about this coronary artery calcium score when it comes to high cholesterol. This is something now primary care physicians have been ordering, cardiologists can order that. So what calcium score means is that the amount of calcified plaque in the coronary arteries. And that's an important precursor to know if you're going to have any events in the future. So when should you consider to get a coronary artery calcium score? If you're not having any symptoms, but you are in between age 40 to 70 and high risk factors for developing heart disease, like if you have significant family history, if you are a current or a former smoker, if you have risk factors like high blood pressure, obesity, diabetes, high cholesterol, or if you're younger than 40 but have significant family history of high cholesterol, then definitely ask your doctor to get a calcium score. How the scoring is done is you can see on the top, on the bottom right, that the calcium score, these are the coronary arteries around the heart, and then that's the amount of the calcium that has built up in the artery. Now, the scoring would tell us that if the score is 0, meaning there is no calcium, there is very low risk of heart disease. Now, also one caveat to this is it tells us the plaque which has calcified, when the plaque gets older, it becomes calcified, but it's not going to show us if there are soft plaques. But still, based on all the research and guidelines, if your score is 0, you still are at lower risk of having heart disease. If your score is 1 to 100, it's called mild calcification and you're at low risk. Between 100 to 400, you are at moderate risk, and more than 400 is at high risk of having events in the future. So if your score is between 100 to 400, or even if it's 1 to 100 based on particular patients and risk factors, you should take medications and control your LDL cholesterol. If your score is more than 400, definitely take the medications, and sometimes based on if you're having significant risk factors, then your doctor may suggest getting a exercise stress test for further cardiovascular risk stratification. In addition to controlling all this that I mentioned, definitely quit tobacco. It's never late to quit smoking, because quitting smoking now will improve your health and reduce your risk of having heart disease, cancer, lung disease, and all other smoking related illness. Weight loss of even more like 5%. Start by that. That can help improve high blood pressure, high cholesterol, and diabetes. Lack of quality sleep is associated with high risk of high blood pressure, diabetes, obesity, and heart attack. So it's recommended by American Heart Association that adequate and good quality sleep for 7 to 9 hours is absolutely necessary to prevent heart disease. Also, now stress has been a big factor in today's world, but perform stress reducing methods at home. Practice yoga, do meditation end of the day or anytime when you feel comfortable. But that just take yourself out of the daily routine and relax, and that would heal your mind and also help you physically. And consider regular visits with your cardiologist because they can know what potential risk factors you have, and then we can treat them accordingly to prevent having any events in the future. Now, talking about women specific risk factors. So before pregnancy, if you have started your menarche, your menses at an early age, that is one risk factor of having heart disease. If you're using oral contraceptive pills, that's a risk factor. Any reproductive disease like polycystic ovarian syndrome or a history of spontaneous loss of pregnancy puts a woman at having high risk of cardiovascular disease in the future. Breast cancer and also treatment at any age related to breast cancer, certain chemotherapy and radiation treatment exposes the patient at increased risk of having heart disease in the future. During pregnancy, if you have gestational hypertension or gestational diabetes, preeclampsia, preterm delivery, or the baby was born small for gestational age, that all puts the women at high risk of having cardiovascular disease in the future. And the risk increases by 2 to 4 times than the general population. So if you're having these risk factors, then definitely see a cardiologist because at least once a year, if there is, like I said, the numbers are controlled, the risk factors are controlled, then there's less risk of having disease in the future. And postmenopausal, of course, menopause itself brings the risk of cardiovascular disease. And if you have premature menopause, either at the age of earlier than 45 or early menopause, which is less than 40 years, that again increases the risk of having heart disease in the future. So when it comes to heart disease and pregnancy, this is the graph that we are looking in the last couple of years, few years, I would say. The graph is just growing high. This is the maternal deaths in the United States by race and ethnicity, and especially the African Americans and the Native Americans are on the higher side, where maternal mortality during pregnancy or right after delivery is just rising. And if we look at the causes of what's causing it, the majority, 34% of it is caused by heart conditions. If you have heart failure or if you had stroke or any heart disease, any congenital heart disease or valvular heart disease, that can increase the risk of death during the pregnancy. And also pulmonary embolism or any clots in the lungs or the legs, especially, and if you have high blood pressure, that can increase the risk of having maternal mortality. And that is very sad. In today's world, we can control and treat these risk factors, these diseases that happens during pregnancy. But unfortunately, because the awareness is low, not everyone is going to see the doctor. People are getting underdiagnosed. And that's why the delay in the care is resulting in all this increment in the complications. Talking about menopause and heart disease. So menopause definitely increases women's cardiovascular risk due to hormonal changes, especially the decline in the estrogen. The estrogen is called the protective hormone. So when after menopause is just stopping your menstrual cycle for at least 12 months. Average age is around 52 years, but if you have an early onset menopause, less than 45 years, or premature menopause, less than 40 years, then it again increases the risk of heart disease and cardiovascular events. Also, after menopause, women may experience a sharp rise in the bad cholesterol and a decrease in the good cholesterol. Women may have high blood pressure and weight gain, especially the visceral fat increases after the menopause. So all the cardiovascular risk factors, they start coming up after the menopause. So now is the time that you start being more serious about your lifestyle and treat those risk factors. There's a question about hormone replacement therapy. There's been so many misconceptions about the treatment, but in general, in nutshell, it is useful if you have symptoms, if you have worse symptoms of hot flashes and night sweats associated with menopause. Yes, it does help reduce the risk of cardiovascular disease, especially if it started within the first 10 years after the menopause and in younger women less than 60. Older women, after 10 years of menopause, it increases the risk of developing blood clots and also stroke. And if you have history of heart disease, then hormone replacement therapy is contraindicated because it significantly increases the risk of having heart attacks or stroke. So talking about symptom recognition, now we know what the risk factors are, how do we control them, what steps we need to take. Now we need to know what the symptoms are. Now there's a misconception that women present with atypical presentation, but women present with women-specific presentation. I know men will have a typical crushing chest pain and with one or two more symptoms like a jaw pain, back pain, whereas women still would present with chest pain. That's the most common symptoms. But then they also have three or more additional symptoms. They would have nausea or vomiting. They'll have dizziness. They can have back pain and jaw pain. They'll have just lightheadedness and indigestion, extreme fatigue, shortness of breath. These are all the symptoms of women having heart attack. So just even if the chest pain is subtle, or sometimes for older women, the chest pain may not happen or start slow and grow slow. But if you're having multiple symptoms at the same time, and if you feel like something is not right with your body, then definitely go get evaluated and advocate for yourself. So the question comes like when you should go to the emergency room. So as mentioned earlier, if you experience any of the symptoms that could indicate a heart attack, regardless of the gender, even if the symptoms are subtle, let the doctors decide. Don't make your own call. Do not wait. Call 911 as time is critical. As we talked about, that when the blood clot forms and the blood flow is interrupted, that starts killing the heart muscle. So that's why if things get delayed, the heart muscle would be affected, your heart function and pumping would be affected. So early intervention can significantly improve outcomes. So make sure you use an ambulance to go to the ER. Don't drive yourself, because when you're having heart attack, there's also high risk of having arrhythmias or funny rhythm or cardiac arrest. So that's the last thing you want, that you're driving and suddenly an accident would happen because of unfortunate events. What symptoms, again, to emphasize, chest pain or chest discomfort. It doesn't always come as pain. Sometimes patients tell me it's just a sensation of something uncomfortable. That can be a sign of heart attack, especially if it's accompanied by difficulty breathing, nausea, vomiting, sweating, dizziness, jaw pain, arm pain, or any unexplained fatigue. Anything that has changed from your baseline, that is an alarming sign, and you need to get it evaluated. So when you go to the ER, I want you to know these are the diagnostic tests that the doctor in the emergency room will consider doing. So first thing they always do is the EKG, which you see on the left side of the screen. An electrocardiogram basically makes sure and tells us if you're having an acute heart attack, or if your heart is injured, or if you're having any rhythm issues that can cause cardiac arrest. So that's something that should be ideally done within the first 15 to 30 minutes of arrival to the emergency room. Because if that's abnormal, and if you're having something called STEMI, which is an acute heart attack, then the door to balloon time, you need to be in the procedure right away, and things needs to be addressed accordingly. The second thing, they'll do the blood test for the cardiac enzymes, which is called troponin. That is the enzymes which, if they are high, it tells that your heart is under a lot of stress, which can be from the heart attack, which can be from other reasons. But with the scenario, if you're having chest pain, if your EKG is abnormal, and if your troponin is high, then again, you need to get further medical treatment and interventions as necessary. Then they may or may not consult based on what the first tests have shown. They'll consult a cardiologist in the hospital, and then after the cardiology evaluation, they would order an echocardiogram, which is the second picture on the screen. It is an ultrasound of the heart that is mainly done to see how your heart pump function is, how it is pumping, and if you're having any major issues with the valves, are they leaky valves, are they tight valve, or if there's anything abnormal with your heart structure or function wise. That's mainly the echocardiogram would tell us that. After this baseline evaluation, the cardiologist would decide if you are stable enough, if there's not too big concern, then they would consider doing a stress test. There are multiple types of stress tests. Common ones are the exercise stress test, where you walk on the treadmill, as you see on the bottom right side, where there will be a physician standing there with a nurse there, and then there's a blood pressure cuff attached to you. There are EKG leads attached, and you just walk on the treadmill. Every 3 minutes, the speeds get faster, gets more inclined, and the goal is to look at the EKG strips and see if there is any strain to your heart while you're walking on the treadmill. And the second option is a nuclear stress test, where either you walk on the treadmill or you get an injection, which increases the blood flow. And then it's followed by a set of images, which is either a nuclear test, or even sometimes they do a stress echocardiogram where they give you an injection and then they do an echo to see if your walls are moving properly or how your heart function is under stress. The second option is coronary angiography. Now, with this new era, we have a non-invasive coronary angiography, which is on the top right side of the screen. Here, you see this. So this is the non-invasive version, which is a CT scan of your heart, but it's an angiography. So here, difference between calcium score and a CT coronary angiography, you would be able to see soft plaques over here and also the calcified plaques. So this would tell exactly how much percentage of blockages you have, and if there is any anomaly or any congenital disease that's there in the heart would be diagnosed. Only caveat to it is if you have history of stents in the past or if there's significant calcification, then it can create artifacts and the test would not be that accurate. And on the top right, you see the invasive angiogram, where it's a procedure where you're sedated and then a dye is injected, and that's the most accurate way to diagnose if you have heart disease or not. So the reason I wanted you to know the test is when, especially for women, when you have to advocate for yourself, you need to ask for an EKG and a blood test, a troponin at least, to make sure that your heart is doing good. And then going forward, the cardiologist can take over and then can do or order appropriate test as necessary. Now, why is women presenting differently than men? Because women have smaller hearts and smaller arteries around the heart, and that also creates high risk of complications after heart attack and even during the surgery. Also, women develop more diffuse and soft plaques, which are hard to diagnose, and they develop it in the microvessels. So as you saw in the previous image, I'll take it back. So you see, these are the main vessels on the top right side, the big ones, but then there are the small thread-like vessels, which are the microvessels, which can be hard to diagnose. And women sometimes end up developing clots and blockages there. So that's why it gets missed. Whereas men develop large, big blockages in the main arteries. So it's going to be easy to diagnose. And also the difference is all related to decline in estrogen, because that can also affect the blood vessels and how the plaque formation happens. So on the right side, you're seeing how women soft plaques diffusely, whereas men is developing a big clump, which is very easy to be diagnosed when they undergo a non-invasive or a coronary angiogram. Also, when it comes to women, both men and women can have, but women is more likely to have different types of heart attacks. So the first one on the screen is a formal heart attack that we know, that where the plaque was there and then the thrombus was created, a blood clot, and that created a heart attack. The second one is a coronary vasospasm. So that usually women would complain of having chest pain at night or in the early morning hours. And it's usually related to either history of smoking or cocaine use, or just the vessel structure is in a way that the vessel becomes tight and then it loosens itself. There's no clot. So there's no stents that needs to be put, but there are medications which can treat that. And of course, leaving smoking and cocaine or any other drugs can help prevent those episodes of vasospasm. The third one is called coronary artery dissection, where there is a nick in the artery of the coronary vessel, and that can create blood flow, a lumen there, and then the blood accumulates there, which is most commonly seen in pregnant female. They present exactly like they're having a heart attack. Their heart enzymes would be high, but when they do an angiogram, they'll find that there's no blockage. So no stents are required again. The only thing needed is medical management, and the dissection should heal eventually. And the last one is stress-related cardiomyopathy, which is also known as Takotsubo cardiomyopathy. So when your heart is under stress, when you have heard some unfortunate news, or if you're going through lots of stresses in life, that can create impact on the heart, and then that can give you, again, same symptoms, but there's no blockage. Your arteries would be crystal clear, but your chest pain, your heart enzymes, and even the heart function would decrease. But then eventually, once it's medically treated and time passes by, the heart function gets back to normal, the chest pain should wear off. But the reason I want you to know is that the other three versions, you don't need any stents. It's all medical management. But the first one, if the blockage is more than 70%, or depending on other symptoms and risk factors, you may need a stent or a surgery. So last but not the least, be your own heart hero. Take-home points would be that heart disease is more common in women, more than all cancers combined, especially if you have history of breast cancer that increases your risk of heart disease. Always get screened every year. Go see your primary care physician, see your cardiologist, and keep your numbers under check. Also, don't ignore your symptoms. If you have any doubts, go to the ER or go to urgent care, go to your primary care physician, let them decide what needs to be done. Ask questions. Do not hesitate or don't be shy to about your any risk factors or about any questions about heart health. Ask questions to your doctor. On a side note, women who have served in the military have higher rates of heart disease than civilian women. And as the most of the lecture was telling about knowing your risk factors and controlling them. So know if you are especially certain race, South Asians, Blacks, people, and also if you have history of rheumatoid arthritis or lupus, anxiety, depression, everything is more common in women, and these all can increase risk of having heart disease in the future. And last but not the least, the women-specific concerns. So during pregnancy, if you have had complications of high blood pressure, diabetes, preeclampsia, preterm delivery, or an intrauterine growth retardation where the fetus is born smaller than the gestational age, or if you have history of polycystic ovarian syndrome, breast cancer, you're on birth control pills, and you smoke especially, and as I mentioned, lupus or rheumatoid arthritis, keep this in mind and then be more vigilant towards your risk factors, as that can increase your risk having heart attacks and strokes and other blood clots in the future. So that would be it. Thank you so much. And for your reference, that's my email address and my office phone number. So if you have any questions, I'm happy to answer.
Thank you. We appreciate you joining us today. We kindly ask that you take a few minutes to answer a couple of questions through our survey program. The link to the survey has also been added to the chat for your convenience. A special thank you to you, Dr. Shah, for dedicating your time and expertise today. If you have any additional questions or comments, you can send us an email to communityhealth@atlantichealth.org, or you can call us at 1-844-472-8499, option 3. This concludes our webinar, and thank you, everyone.